Good morning to everyone. It is really a pleasure to welcome you to this dialogue organized by CLACSO, the Latin American Council of Social Science, and the Public Health Agency of Sweden, to address one of the topics of relevance in the world today, the response of the countries to the pandemic caused by coronavirus. In particular, today we will hear about the Swedish model and the lesson learned so far in dialogue with Latin America and the Caribbean. As we know, public health and diseases prevention and control is very much about global networking, and that is why it is so important to learn about different experience and to compare how different regions and countries are dealing with this pandemic. Let me introduce you our guest today. First, we will listen to a brief presentation from Mr. Dr. Anders Tegnell, Deputy Director General and State Epidemiology of the Public Health Agency of Sweden. He has been the Swedish state epidemiologist since 2013. He's a medical doctor with a PhD in infectious disease, and he has several years of international experience from working with WHO, and he has also extensive experience of leading different Swedish government agencies at different levels in the field of public health and disease control. After his presentation, Dr. Tegnell will then dialogue with Gonzalo Basile, who is coordinator of CLACSO working team in international health. He is part of the Latin American Faculty of Social Science in the Dominican Republic, and also with Marinilda Rivera Diaz, who is also the coordinator of our working team in international health. She is from the Social Research Center of the Faculty of Social Science in Universidad de Puerto Rico. Let me especially thank all of you for accepting this invitation, and we want to start right now with the activity. So, Mr. Tegnell, the floor is yours. You have half an hour, if it is okay for you, for your presentation. Thank you very much.
Thank you very much for the kind invitation, and I couldn't agree more with you about that. This is really a time when we need to share experiences all over the world, all having these pandemic that we all need to deal with in different ways. So I'll try to So I hope everybody can see my screen.
Yeah, it's perfect.
Very good. So let's get started. Just a few things about Sweden to start with, to put it in some kind of context, since Sweden is fairly far away from most of you. We have a population of 10 million, which makes comparison quite easy in many different ways. But our demography is quite unusual, I think, for many countries of the world. We have 20% of our population about 65 years of age. We have a fairly long life expectancy, with males almost 82 and females almost 85 years. We have an extremely low maternal and child mortality rate. So altogether, we have a very high level of public health, I would say, in many ways. We have, which is also important to know, and I think that's shared with many of you, that we have a very decentralized healthcare system, which is to a great extent the responsibility of our regions. But it is publicly financed by a tax levied at the regional level. So it's highly subsidized. The amount of money you need to pay for yourself is very limited. The Public Health Agency in Sweden, then, it's one of the national agencies under the Ministry of Health and Social Welfare, and have an extensive responsibility in the area of public health. I'll come back to that. We do also work with WHO in many different ways. In this context, it's good to know that we are the focal point for the international health regulation, which is very important these days. We do a lot of communicable disease prevention and control work also in regular times, but even more so now. We do some research of our own, but we have a lot of collaboration with different universities, not least the Karolinska, which we reside on the same campus. So what do? We collect and analyze and report data in all different parts of public health. For example, we monitor the vaccination program in Sweden. We also have the National Reference Laboratory as a part of our agency. We do a lot of preventive health work in many different areas, all the way from mental health, lifestyle in different ways, gambling, almost anything you can think about. One of the main areas of our activity is really to promote and monitor health equity, which is still a problem in Sweden. And as I said before, we do have a number of international collaborations going on. So what has happened with COVID-19 in Sweden so far? We have a fairly large pandemic in Sweden, as many of you probably know, with 50,000 detected cases so far. We had 2,300 patients that been in intensive care over the whole time. I think currently some 400 or 500 are still in intensive care. And we have an unfortunate level of mortality with now over 5,000 deaths as of today. The mortality is one of the areas of our concern, and it has been an area of concern, I think, in many countries. I think that the Swedish experience very much mirrored experience in other countries, which has had a high level of mortality, that the mortality is very much focused in the elderly age groups, especially in the age group above 85, as you can see on this graph, while mortality under 70 years of age is rare, and the farther down you go, if you go below 50, it's extremely rare. And this, I think, looks the same way in Sweden that it has in many countries. You can also see that males dominate, except in the eldest age group, but that's mainly because we have more women in that age group than men. And so how far in the pandemic is Sweden? We have talked a lot about herd immunity in Sweden, and we have tried to measure the immunity in many different ways. It proves to be very difficult to measure herd immunity. And I'd be happy to come back to that and discuss your experience in that area, because it is a tricky area. In one of the last surveys we have done, the zero prevalence in Stockholm region, which is the region that's been hardest hit, is slightly above 10%. It differs in different age groups, while children have a lower zero prevalence, and the above 65 has quite a lot lower prevalence, which we are quite happy with, because that's the group we try to protect very much. But it also differs very much between different regions in Sweden, in a way that's a little bit difficult to completely understand. So what's the basis of our response? I think we base our response very much on historical values and historical regulations in Sweden. It's a shared responsibility with advice from our agency and other expert agencies and the regional medical officers. Each region has a medical officer in charge of communicable disease control. And what we are trying to do, which I think many countries are trying to do, is to flatten the curve as much as possible to slow down the spread of infection. And the second important thing we try to do is to protect our risk groups. And in Sweden, it's mainly the people above 70 years of age. We have, from the very beginning, realized that this is something that's going to stay with us for a long time. So we have looked very much at sustainability in the response strategies and how to adjust them over time. And we also are well aware of that this response might have a number of other impact on public health in many other ways, and we will also try to figure that in when we discussed what response we have. But basically, we're talking, like in many countries, about social distancing and hygiene routines, which is the basis of, I think, most of our responses. So What have we done in practice? We have kept kindergarten and school open up to high school, which is the grade 10 in Sweden, mainly because we believe that it's very important for children to be able to go to school. We have told people that can work at home to work at home as much as possible, which is quite a substantial part of the Swedish workforce can do that these days. We are a highly digitalized country, I would say. We know that restaurants and cafes are really an area where there is a high risk of transmission, and we have given a number of rules and regulations to cafes and restaurants so that people coming there really don't have to have close physical contacts more than absolutely necessary. So what we have told the public is to, as I said, stay at home if you have minor symptoms. We really believe that this disease can start with really very, very slight symptoms, sometimes almost no symptoms at all. You need to think about physical distancing, not coming too close to people anywhere, especially in collective transport and in the workplace. Good hand hygiene and other basic hygiene routines are also important. We did a lot of contact tracing during the first few weeks. The disease was really introduced in Sweden during the spring holiday for people living in Stockholm and surrounding areas, while a lot of people traveled to Central Europe for skiing and other things. And a lot of people came home with the disease, and we did a lot of contact tracing among those. Testing was one of the weak spots to begin with, but it's been scaled up, and currently we are testing, I think, almost 70,000 people a week. So we try to limit transmission as possible, limit transmission as much as possible to slow down the pandemic and protect the risk groups in different ways. But how do you get social distancing into place? We have worked with a number of different measures. This is a combination of regulations and general advice. The regulations of the binding regulations is that there is now a ban on visiting nursing homes, that we have told secondary school and universities to do distance education. And we have gathered mass gatherings, first at the level of 500 and later at the level of 50 people. And then there has been a number of messages to the public, as I said before, to stay home if you're sick and stay home at least another 2 days. These recent days, there is also a lot of more possibilities to get tested. So in many ways, we also tell people to go and test themselves if they feel ill. We have given a lot of special messages to the 70 years and above people to avoid physical contact as much as possible, to stay at home when needed, but also it's possible to be outside, especially this time of year in Sweden. And then you could meet people as long as you have a safe distance. And we have avoided unnecessary travel up to just a few days ago, when we said that during summer holidays, you are allowed to travel if you just travel responsible. So healthcare services have taken a large brunt during this pandemic, as it has in many countries, but in Sweden has kept on working very well in many ways, even if there has been a lot of adjustments. Elective surgery, when possible, has been postponed. It has been a great challenge to get protective gear into place, but it has worked all the time. Overall, the number of ICU beds in Sweden was increased almost twice as many as normally, but it's now decreasing again when the demand is decreasing quite quickly. And especially the healthcare in Stockholm and the surrounding regions have a high burden during this time and been quite stressed about that. And there has also been a number of other adjustments in healthcare to avoid transmission as much as possible. And the background, it's very much a Communicable Disease Act from 2004, which gives a lot of responsibility to the individual. It is also pointing to the need to have evidence-based measures in place. And it has also developed over the years in Sweden, a lot of trust between the public authorities and the citizens. We do have an extensive surveillance system in place in Sweden. We follow cases, diagnosed and mortality very closely. We do have groups of people looking at the scientific literature. As you know, it's expanding very, very much. It's a tsunami of new articles every day, almost. And we do have a lot of dialogue like this one with a number of different partners all over the world. Of course, with a complicated pandemic like this one, which we knew so little about in the beginning, there was a need to adapt it over time. We have monitored risk groups very much, elderly migrants and so on, and try to adapt the response in their areas as much as possible. We have had a special problem with nursing homes where a lot of the mortality has taken place, and we've given a lot of advice to them on how to improve hygiene procedures and protective procedures in different ways, which has had a lot of impact. We do have a lot of migrants in Sweden, people born in other countries, and we have also developed information in a number of different languages, among them Spanish, I'm sure. We have also worked very hard with communicating. We have had daily press conferences now for several months. We are cutting down on them slightly in the last few weeks, but that has also been quite important. And what has the public thought about this? We have looked at that in a number of different ways. We know that they have adjusted their daily life very much. At least 80% of the people tell us that they have adjusted their lives in different ways if you ask them. There is a very high level of public trust in the public agency and in healthcare institutions in general, much, much higher than we've ever seen before. So we have a great compliance with recommendations so far. There is some signs that we are a little bit losing this, but it's still on a very high level. And we can see that in different ways. We can look at how much people have stopped traveling by following the mobile phone operators and their data. And we can see that Sweden has diminished its travel, or people in Sweden have diminished travel just as much as our neighboring countries. Many of them have used legal measures to stop people from traveling. So doing things in a voluntary way works very well in a number of different ways. But as I said before, one of the major tasks of the public health agency is really to look at health inequalities. And this pandemic has also been very unequal in many ways. And also response, of course, is different, how well it works in different groups of the society. It's not so easy for everybody to work from home, as one example. It's not so easy for everybody to avoid public transport, etc., etc. And there is a lot of side effects from a pandemic response, as you're well aware of. Unemployment increases, income drops for many groups of society, especially the vulnerable groups. And it has been quite important to keep essential healthcare services in place, and they have been in place to a great extent, I would say. We don't see any high level of other kind of diseases developing. There's been a lot of discussion why Swedish strategy is so different from other Nordic countries, especially and also other countries in general. I think to a great extent the difference is exaggerated. In many ways we try to do the same thing. In Sweden we have used voluntary measures much more than legal measures if you compare to many other countries, but in many ways we have achieved the same kind of effect. And this is very much due to the history behind this. But the pandemic has also developed very different in our Nordic countries. And it's, I think, too soon to understand why, but obviously the pandemic has run a much more difficult course in Sweden with many more cases and many more deaths. And if that's due to difference in strategy or if that's due to other reasons, we'll have to wait and see. So what have we learned so far? How important to have sustainability in the approach. We can see that even the Swedish strategy is hard to keep in place over time. And we know that many other countries in Europe have a much harder time than we to keep their measures in place over time. We need to use even in rich countries like Sweden, to use our resources in a responsible way. And we do know that lockdowns seem to work, not everywhere, but in many countries, but they have a lot of consequences, and you need to be able to handle those. And to keep essential services in place is very important, also in Sweden. They have been in place to a great extent, but we're also following that very closely to see if there will be any bad effects of that. Because of course there is always a risk of suppression of other health needs, and we have seen that people come to emergency service much less than they usually do. If that's going to have an impact on health in the long run or not, we'll see. So to end up, this social distancing, physical distancing is very important. The words are quite difficult to translate well into Swedish, and we say that you need to keep a distance, but you should still be able to socialize with people in different ways, because having social contacts is a very important part of public health in many ways. So thank you very much. That was all from me at this time.
Thank you very much, Mr. Tegnell. It was really a very interesting presentation. So let's continue with this activity. And before giving the floor to our researchers, let me tell you that in CLACSO, in the Latin American Council of Social Science, we have a network of researchers on public health who are working in Latin America and the Caribbean. And this network is articulated with public policies and have several productions and publication on the treatment of the pandemic in the region. Anyone who is interested can see all these publications and these short pieces of papers. And in our webpage, we have social observatory, who is that is called Think the Pandemic, where we have more than 200 articles, short articles around this issue, and obviously some of them are specific from a public health perspective. But now let's listen to our researchers. I will give the floor to Gonzalo for 10 minutes and then to Marinilda for another 10 minutes. Okay? Gonzalo, if you want to start.
Thank you, Karina. A pleasure for this meeting, and nice to meet you, Dr. Turner, Dr. Melin. I am Gonzalo Basile, Argentinian, epidemiologist and social science, research in international health and critical epidemiology. But a quick presentation for this debate. What minutes? Okay. This look okay?
Perfect.
Okay. Okay. Only a three quick questions for the time we have. The first question is the need thinking about the epidemiology in the global south. This involve big change, change for the example in the invisibility and fragility for the public health system, the polarization of inequalities in health, but Marinilda about talk this, and that is to say, think of the collective health in Latin American and Caribbean, feel the complexity feel the multidimensionality and feel the multi-level of study. Okay. The second question: what is this epidemiology for the social medicine or the Latin American social medicine? Let's start with what is not epidemiology for social medicine. It's not just a statistical measure. They are not clinical study or infectology. And it's not just making cognitive inference, and it's not the analysis of clinical individual cases. And the second epidemiology study the distribution and determination of the population health and the inequality distribution in the society. And the second question is an integrated model and understand study for the social determinant of health in the complexity, and the model integrated for the complexity critical model for the health social determination. Is the level individual, the level in the class, in the level in the society. In the integral, the field of health and epidemiology in these parts. Well, the level of analysis and explanation for the health disease process in the disease health express and the general level and the general in society and the particular community and the individual is singular. But the several of ill or epidemics disease of the COVID-19 in a particular context, in a particular moment, and in a particular population. For example, Manaus in Brazil, Guayaquil in Ecuador, San Francisco de Macorís in Dominican Republic, Lima in Peru, Santiago in Chile. What are we observing COVID-19 situation, different situation in Latin American and Caribbean. But what is the epidemiology in Latin American and Caribbean context with the coronavirus or COVID-19? One, fragility and segmentation of the public health system victims by the neoliberal reforms. Second, inequal society, no universal social protection. Third, distribution of disease by social class, ethnic, and gender. And fourth, disintegration and regional incoordination in the public health response. The Latin American context, the public health system, in other words, is very difficult for the prevention and control infection and responding to the healthcare demands and low quality and humanity of care, the centrally in this hospital with low capacity of basic health network, except maybe Cuba and Costa Rica, poor working condition and no protection of the health workers. But the Latin American context is this million the families in the cities and after extreme poverty, extreme life condition and healthy. The second choice is the situation by regions for the Latin American, Caribbean in comparison for the Europe and USA, but one point, the critical situation, or note the critical situation is one, access to the confirmation diagnostic test. or testing, diagnostic testing criteria, different diagnostic testing for the clinical criteria, epidemiology criteria is difficult in the virologic and epidemiological surveillance system in with countries. The comparative table for the duplication of the confirmed case in this table, very strong for the Brazilian situation, Peru and Ecuador for the situation, and this Cuba for better results. The trend curve for the situation for the confirmed cases is the Latin American. And the confirmation table for duplication of that is the situation in Latin America, in only 11 countries, but Brazil, Ecuador, Peru, Mexico for the situation, very complicated situation. And the trend Cuba, the better situation. This is the trend curve for the death speed and situation in Latin America. But the C global trend curve and for Latin American and Caribbean is very, very difficult for the example, the fatality rates not served for the understand of the risk of the death is not a association rate, only frequency. We know the number of cases, but know the total number of patients, and there are many people without diagnosis. For example, in fatality rate, Chile looks better for Argentina, but Cuba, Dominican Republic, for better than Cuba in the fatality rate. But maybe I will look the mortality rate, the specific mortality rate. We actually, for Argentina has a better mortality rate than Chile, and Cuba much better mortality rate than Dominican Republic. These five countries with the critical situation, specifically Ecuador, Peru, Brazil, Chile, Mexico. Many questions appear in the response to the pandemic and post-pandemic. The question centrally does the wave of the disease post-pandemic, the surplus morbidity post-COVID, and the very answers for the Latin American and Caribbean. The three answers is here, but the very answers for the question centrality, and reflection for the pandemic and post-pandemic. No, the wave of other disease post-pandemic in this, very difficult for the Latin American and Caribbean, and centrally in the securitization and militarization of health control is this situation for. The finally is the first. I work and strengthen post-pandemic and work and strengthen for pandemic. First, a critical epidemiology study on response to pandemic. The critical and the studies for epidemiology, for social science and health science. And the second work is the international health in case for the soft and decolonial geopolitics, for the strategy for the sanitary sovereignty for the people health. This is for prioritization for Latin American and analysis in this pandemic and post-pandemic. Thank you.
Thank you, Gonzalo. Thank you very much. And let's give the floor now to Marinilda. I don't know if you have a presentation, Marinilda, you have 10 minutes.
Yeah, let me check. Okay, now.
Okay.
Presentation now.
The floor is yours.
Can you see the presentation? Let me.
No.
No. You have to return to PowerPoint and then put this full screen there. Not Zoom, sorry, the other. Thank you. You have to click there in the, no. in PowerPoint, you have to click, and full screen.
Okay.
That's it. Now, yes, thank you very much.
Oh.
No?
Okay.
Once again, please.
Okay, now. Yeah. Now. Yeah.
That's it. Thank you.
Well, thank you to all of you for this opportunity. It's a great opportunity to learn from other countries also. The title of my brief presentations remind me a question one person in a previous forum, maybe when we started the pandemic, asked me. She asked, do you think this pandemic threatened the life of all people? And I responded, yes, but not all of us are in the same conditions to face it. I think this pandemic are giving to us the same broth, but not in the same cup. And now in the pandemic times, we realize that inequality also counts in the equation for surviving. Before I start, I would like to highlight that the current pandemic of COVID takes us in a critical moment, maybe the worst in the recent history of our Latin America and the Caribbean countries. This marks specific differences in how responses to the pandemic are articulated both from the state and from the society. Neoliberal policies implemented during the 80s by privatizing social rights, such as health, followed by a wave of austerity measures and a structural adjustment for the payment of the debt of our countries, lash out against a weakened system of welfare and social protection, and has created a critical scenario that places us in a very fragile position economically and socially to face this pandemic. Okay. For my presentation, I would like to apply very briefly 3 out of 6 dimensions of analysis we have developed through the working group International Health and Sanitary Sovereignty of CLACSO since the first case of COVID was reported in our region. These dimensions are part of a theoretical and conceptual framework to conduct our work during the last 5 months. The first thing that I would like the first thing is to understand the connection between society, the biology, and the nature. It is related with the epidemiological dimension and the origin of the pandemic. This is more focused on problematize how this epidemic is originated and the context in which it arises in China. Since the beginning of the pandemic, maybe you remember the discussion about its origin focused on the cultural habits of Chinese people and unhealthy management of food in Wuhan market. It must be clear to us that we are facing is neither natural or something catastrophic that is out there and is attacking the humanity. Rather than, we must recognize that the destruction of the earth, as we have been doing for the benefit of the capitalism and the production of accumulation of capital, has created the basis for the emergence of epidemics like COVID and others. Capitalist practices using the earth as a main resource have been a mechanism of capital extraction for northern countries in the southern countries. In our Latin American countries, this is manifested through extractivism, deforestation, agricultural exploitation, and business, generating consequences such as transformation in the immediate ecological system of the people and the environmental contamination, forces displacement of community, food insecurity, exposure to new viruses, bacteria, and new diseases, high incidence and prevalence of chronic diseases and mortality rates, and extreme poverty. Of the 20 most economically unequal countries in the world, 8 are in Latin America, making it the most unequal region in the world. These created consequences put the life of many Latin Americans and Caribbean people in a difficult situation to respond to the measures imposed by governments inside our countries, especially for women. Gender takes a central place in this discussion, and I will come back later on this topic. According to the Economic Commission for Latin American and the Caribbean, 107 million women in our region live in poverty. 51.8% of women are employed in precarious sector with low wages and labor rights and depend mainly on their work and income to guarantee the life of their families. The second dimension is to retrieve the gaze on the pandemic from collective and public health. And I say retrieve because this has to do with the urgent need to understand that people are the ones who suffered from the epidemics and pandemics. And these require approaches from this dimension, and not only from the individualistic biomedical model that is what is prevailed. We have seen how the biomedical approach has focused its intervention on symptoms and illness person as at risk and in need of treatment. From an individualistic and discontextualized perspective of the relationship between society and nature. Clearly, this model leaves us the social dimension of health, and therefore leave us without clear lenses to look at the causes of the causes that make some sector more vulnerable to the pandemic. Observe how recommendations from this model indicate stay healthy, drink enough water, avoid stress, negative thought, eat well. The person under this model is responsible for their health. Then, based on this approach, the governments are giving responses to the pandemic, which generate tensions between sectors that are not in equal condition to comply with the measures. It is not due to lack of will, but due to preventable and unfairly social and economic conditions created by local and international policies to which they have been subjected. In other words, due to the social inequality in which they live and the health inequalities that they face. Sen defines social inequality as the unequal distribution of social and economic resources, including power and prestige in society. In the case of power relation, Foucault has argued that this has been governmentalized, that is, developed, rationalized, and centralized under the institution of the state. One of its capabilities is to max itself through policies that may seem like beneficial response to the population, but that have deadly power in those who have historically remained on the margin. I bring this because we have seen the violence socially generated towards those people who cannot comply with the stay-at-home discourse. This social inequality creates also inequality in health, which are the differences in health indicators that occur socially, since their origin is political, economic, or cultural, and that they are unfair, since they are generated through unacceptable situation that must be and can be avoided. This is lived daily by thousands of people who face limitation to access medical services. This brings me to the third dimension, that is the socio-political and dynamics from the state and society to respond to this pandemic. By this, I also mean the response of the health system of our Latin American and Caribbean countries to the COVID-19. It seems important to me to keep in mind that all epidemics and the responses that are presented to address them from society and the state take place in a political, economic, and social context, as mentioned by Gonzalo. The responses for the management of the emergency produce tension dynamics between sectors, particularly those who had hold powers against those social sectors that have been historically marginalized, those that for Boaventura de Sousa Santo make up the South. The South not as a geographical space, but as a metaphor of the human suffering caused by exploitation and discrimination. It's important to me to mention two groups from the South as identified by the Sousa Santo, who have been most violated in this pandemic and in previous emergency also. Those are immigrants and women and girls. Many immigrants have been victims of forced displacement, facing challenges to access healthcare in foreign countries for their migratory status, stigma, persecution, and violation of their human rights. Recent publication on Latino immigrants identified them as the most vulnerable population in the United States due to many factors, including accessing testing and treatment for lacking health insurance, many living in poor communities with high infections and death rates, and poor working conditions and exploitation. To give you an idea, 7.1 million non-authorized immigrants lack health insurance and as a result don't have primary care today in US. Women and girls are the other group. In a society where women predominate in the field of care, such as nurses, social workers in a scenario of protection and social response, in care of ill people, and in the domestic setting under the care of children and families, compliance with quarantine is a challenge. On the other hand, in a capitalist patriarchal society, the tag of care is imposed to women. In times of coronavirus, the new demands imposed in the domestic space, such as remote work or telework, become additional stressors that worsen their physical and mental health condition. Exploitation in the domestic space is imposed like the new normality, but it's an exploitation that generates wealth for the economic system, since there are tasks that remain in the unrecognized, invisible, and unpaid scenario. New demands to confront the coronavirus are not being sensitive to this reality, which is why the call by feminist movement and other sectors to a quarantine with a gender perspective. Also, for many women and girls, a stay-at-home discourse is synonymous of hold on degradation, the violence and rape. For example, in the first week of lockdown, Peru, Argentina, and Bolivia saw the largest increase of violence, as well in Puerto Rico. On the other hand, understanding the current responses of health system in our country also requires understanding the effects of neoliberal policy for the past 4 decades on health system, social welfare, and labor protections. We must remember that in the 80s and 90s, several health reforms were undertaken focused on treating the economic and aesthetic problem of the system. To achieve this, countries increased the presence of the private sector in the health sector by integrating private options for financing and providing health services and contracting for profit insurance companies. Consequently, there was a significant reduction of the role of provider by the state in health sector and other social areas, which further limited actions to intervene in the social determinant of health. For example, a structural adjustment program in many countries sometimes require drastic cuts in the areas of social, housing, and labor protection. These policies triggered inequality between rich and poor, increased poverty, and weakened the state as a guarantor of the well-being. Today, some Latin American and Caribbean countries, sadly, have been adopting an agenda for emulating the health system model of the United States. This model is one based on for-profit coordinated care management, the most expensive in the world and with poorly healthy population. Official reports indicate this country spent 17.1% of its gross domestic product on health. However, it is not reflected in the epidemiological and health profile of the North American society. This health model has been as lethal as the coronavirus. Just look at some studies from Johns Hopkins University, where it states that the third cause of death in the United States prior to COVID-19 was due to medical error. But these statistics doesn't terrify anyone. They do not appear as a cause of death in the Center for Disease Control, and they are not discussed in the news. However, we all know the origin of this epidemic, and we also know of the existence of its cures.
Sorry, Marinilda, 1 minute.
I'm finishing 1 minute.
Okay.
So I would like to conclude that the crisis Latin America and the Caribbean countries are facing are not only to the coronavirus. It was there before, historically unfairly created. Also, the lethality of this virus doesn't necessarily lie in it, but in the living condition unfairly created by the socioeconomic system through the exploitation of our lands, the privatization of common goods, and the social rights. Those conditions have forced the South to artificially survive, leading us to live in conditions of inequality that is the worst disease on the planet. In this time of pandemic, it has become clear that health is enjoyed from the collective, and it cannot be beaten on save yourself if you can. My health depends on the others. I think this emergency is giving us all the same broth to drink, although not in the same cup. And now, in this time of a pandemic, we realize that the health of those who live in the South matters. Thank you very much.
Thank you. Thank you, Marinilda. Really interesting, your presentation. So we have one question addressed to Mr. Tegnell, and then I would also like to invite all of you to react to the others' presentations. So we have sometimes 10, 15 minutes more before we end. So I will read the question addressed to Mr. Tegnell and then give the floor to answer and also to react to each other presentations. So the question, you can find it there, Mr. Tegnell, also in the question and answer section. It says, what are the Swedish authorities' response to increased gender inequality during the epidemic? For instance, has distance work been equally for women and men? Has the fact of maintaining kindergartens and schools open been done also to maintain certain level of gender equality? Or what were the motives for not closing the school beyond the importance for children in staying in school, taking into consideration that in Latin America, the effect of the pandemic has particularly hit hard on women taking care of children and elderly, adding new tasks of care. Thank you. So this is the question for you. And also I give you some minutes for maybe reactions or comments to Gonzalo and Marinilda presentation.
Thank you very much. First to the question. We have not really seen any signs of that inequalities in Sweden has changed during this time. I would say that women and men there is no huge difference in the possibilities to work from home. There will be a certain difference because women are more involved in healthcare and care of the elderly. There's a larger part of the workforce is female. So of course, there will be. On the other hand, men have been harder hit. There are more men quite a lot more men in intensive care. There are more men in our statistics of cases altogether. So it has obviously not meant that women are worse hit by the pandemic than men. If you relate to the disease. Of course, there are other things you can think about. I would say that keeping schools and kindergartens open had to do with a lot of things. To keep the children healthy, of course, is important, but also to keep the possibility for both men and women to continue working, especially in healthcare. And I think that has been very important. And our healthcare services have been quite concerned when they've seen schools close in other countries, because they know that will take away a lot of their workforce from them. So in that way, I think this has also meant that women has not been harder hit during this time than normally. And finally, I mean, two very interesting presentations. I think we have in Europe and in the world in general talked too little about all the side effects about this pandemic, how it's really had put pressure on our health system in different way, and shown weaknesses in our health systems and also in our broader social systems in a way that I think we will probably discuss and talk about a lot in the future, because it has really shown a lot of things in our society that we have not been all that much aware of in the past. So thank you very much. Very interesting.
Thank you. And maybe now, Gonzalo, it's your turn. 2 or 3 minutes. The micro. You have to put on your mic, Gonzalo.
Yeah, now.
Yes. Only the one question for the Dr. Tegnell. What's observed by the securitization and militarization of the global health agenda?
Maybe Marinilda, if you have reactions or questions to Mr. Tegnell, and then I give back the floor to him.
I'm fine. I think that the only question that I have for Dr. Tegnell is more if he's seen any difference between the effects of this pandemic on gender and like women and girls in Sweden, and the effects of this pandemic, especially on maybe people living in poverty with chronic health conditions. Because for our experience, we have been seeing a lot of inequality, as I mentioned, in this population. And obviously, this pandemic attacks people differently. So for me, it's important that maybe he can explain a little bit some gender issues around the pandemic in Sweden.
Thank you, Marinilda. Mr. Tegnell, your final reactions?
Let's take the last question first. As I said before, we are doing work now, looking at other kind of effects of the pandemic than by the disease itself. And we're doing a lot of sending out questionnaires to people and so on. And there we will be able to measure if this has had any gender differences in a way it's been hurting people aside from the disease itself. The disease itself definitely hits men worse than women. That much we can very easily see in our statistics. But if there are other effects of the pandemic that gives more of a gender inequality or so on, it remains to be seen. There is no obvious sign so far. We have though seen that people with moving to Sweden from other countries, or born in other countries, are worse hit than people living in Sweden. Especially in the beginning of the pandemic, that was very much so. We have a large group coming from Somalia, as an example, that was really badly hit in the very beginning, with a lot of cases and a lot of deaths in that group. So there is definitely a socioeconomic aspect to this disease that cannot be disregarded. And that's, of course, due to a number of different factors, the kind of work they do, how they live more in a more cramped lifestyle than many other people in Sweden. So, and we're also looking into that over time. We have a report where we very clearly can show that these people have been much harder hit, sometimes 4 or 5 times worse hit than the general population in Sweden. So that's an important aspect. For the first question, I think that's, if I understand you right, I think that's an interesting aspect. And I'm often thinking about the difference between the response to the swine flu pandemic a few years ago and the pandemic we have now, and to what extent the changes in the political climate affects that. Because the way this has been dealt with, very much with border closings, closing down societies, very much sort of closing up our countries, and not talking about international collaboration and things like that at all this time. I think that is very interesting compared to the swine flu pandemic, where those kind of issues was very much more on the table. Everybody kept their borders open, and there was much more of a collaboration, definitely within Europe, I would say, but also in the world in general. So I think that's something worth discussing, and I'd be happy to discuss that at some other stage, why we have ended up in this kind of very political, very legal response at this time. With the pandemic, that's of course worse than the swine flu pandemic, but not that radically different. So why did we end up in these kinds of very security-based, very political, very legal kind of measures? I think that's definitely a very interesting aspect.
Okay, so last, I would like to thank you, all of you, for your presentation. They were really good and interesting. Today, we in Claxo, we begin this dialogue to which we want to give continuity and advance also maybe in conducting some comparative studies looking to the different dimensions of the pandemic and the post-pandemic effect, to the side effects also, as Mr. Tegnell said before. Last but not least, I would like to especially thank to Pablo and to Malin for organizing all this dialogue and this seminar, and let's keep in touch, and let's keep dialoguing around all these important issues. Mr. Tegnell, special thank you to you. Gonzalo, thank you very much. And Marinilda, thank you also very much. Pablo, I think we are done. Yeah, maybe you want to say something?
No, I don't know if Malin want to say something. Malin, if you like it, if you want it. No, okay.
Okay.
So
no,
thank you very much.
Yeah. Thank you very much to all of you, and
thank you very much.
Let's keep in touch. See you, and bye-bye.
Bye.
Bye-bye. Thank you. Bye-bye.
Thank you, Mr.